Thanks for joining us this evening on the next series of the Fireside Chat. I'm David Beret. I'll be moderating tonight's session on proximal humerus ORIF. I'm joined by a couple of friends and colleagues, Hobie Summers and Michael Gardner, to go through some of this. And I think that they'll give us some really good perspective on challenges with these particular fractures. All of the conflicts that you see here have been sorted out beforehand, and there is nothing that's really going to affect any of the content here, either for myself, Dr. Summers, or Dr. Gardner. This is a CME credit, and there'll be a link that you can do some questionnaire afterwards, and then access your certificate and claim your credits. This is just a rough outline. This will be our maximum period of time, about 90 minutes spent here. I'll take care of the first 5 to 7 minutes or so with this introduction. Then we'll transition into Dr. Summers talking for about 15 minutes or so. And then Dr. Gardner and I going back and forth with Dr. Summers about some of the content and some of his case presentations. We'll segue into Dr. Gardner's session once again, followed by some discussion. And we were trying to make this as interactive and case-based as possible. I think for this particular fireside, this is the spirit of how the fireside chats used to be back in the day. A lot of us just bantering back and forth about cases and how we talk about things. Dr. Gardner is going to review a really cool journal article on technical factors affecting fixation stability that I think will lend itself well to some of the summary about this particular topic that we're going to be going through. And all the while, you've got a Q&A function on this Zoom. Please feel free to type up any of your questions, and we'll either get to them verbally as we see them pop up, or can type them. And I'll tell you right off the bat that I'm not particularly slick with working the Zoom, but I'll do the best I can at managing some of these questions. So hopefully at the end of this is just some general stuff. The guys will present their own objectives for you to be able to, at the end of this, describe the surgical tactic in a step-by-step approach for the reduction and fixation of proximal humerus fractures. I'm going to come right out of the gate and say the purpose of this webinar is not to discuss who should get a sling, who should get an arthroplasty, what kind of arthroplasty they should get. We're going to assume that the decision to go ahead and proceed with ORIF is right in front of you. You've made that decision, and we're going to focus a lot on the technical aspects of reduction, the technical aspects of the fixation. And hopefully by the end of it, you can list some of these reduction and fixation parameters associated with proximal humeral ORIF failure, and then be able to anticipate failure modes based on your injury radiographs, based on some of the data that's going to be presented tonight, and based on some of the experiences that we've had and are going to share with you tonight as a way of mitigating those particular complications that you may see. So just in starting off today, I'm going to present 3 cases. And I'm not going to give anybody anything more than these 3 cases. But I'd like us to just kind of look at their injury x-rays, or what I've presented up in here. The case 1, a 68-year-old male who has a ground level fall walking the dog. In the center of the screen, you can see a case 2, 32-year-old male, more of a high energy car wreck. And then the next case is 55-year-old male who has a fall from a ladder. 3 very different fracture patterns, 3 different bone qualities, 3 different energy mechanisms. And so I'm just going to pose to Mike and Hobie, when they look at these injuries, what do they think? What do they automatically start to consider or to think of anything? How they might fix it, how they might approach this? What are the pitfalls when you look at just this injury x-ray? Mike, what do you see with case 1? What do you think about that one?
Yeah, so case 1, falls into this category that I think we're learning a little more about, which is this posteromedial roll-off. And we think a lot of varus valgus, which is important, but this posteromedial pattern often kind of fails in shear. And so, I see this as pretty inherently unstable, but I think it's a pattern that can be made very inherently stable with an accurate reduction. Augmentation is often considered, kind of depending on intraoperative findings in a patient of this age. And despite it being inherently, I think pretty inherently unstable, possible to treat non-operatively as well, just with the shaft contact in general.
Excellent. Hobie, can I ask you, when you see case 2, what do you think about?
Yeah, so the kind of wildly dislocated proximal humerus. It looks like he looks like he may have had the fracture before his reduction attempt. Looks like maybe some of his tuberosity is left behind in his injury x-ray. Then he had this post-reduction attempt and his head is left, looks like it's left behind quite a ways away from his glenoid there. Am I reading that right, Dave?
Yeah, exactly.
Yeah.
His imaging that I didn't include with this particular slide does show he has a fracture of his anatomic neck with it being minimally displaced,
Yeah.
but it is present. There's a fracture line there for sure.
Yeah. So attempted reduction, left the head behind. That one is further dislocated than I've ever had at my place. But I think in that age group, even with the fracture dislocations and the head gets left behind, I typically still work on fixing these. I think getting a good CT, figuring out exactly where that fragment is and how you're going to get the head fragment out of there is going to be one thing. Also understand what the tuberosities are doing. It's hard to tell on our x-rays, but they might be together actually, and it might just be the head that's left alone by itself. CT for me is paramount for that one. I got to figure out how I'm going to try to get that out. And my goal would still be to try to fix that in a 32-year-old.
Mike, do you have anything that you want to add to that one?
I do. Yeah, we've had a few of these actually, and one had a diminished radial pulse, and so we got a CT angiogram. And when the head is juxtathoracic like this, I think you always need a CT angiogram. We had another one last week, normal rate, normal pulse. Got the vascular surgeons to expose the axillary artery just to have some protection. And then we fished it out with no problem, but having them there was covered. So anyway, I think you need to recognize this as a potential vascular issue and do a vascularly extensile approach. Even if you don't get the vascular surgeons, you don't want to try to do this through a deltoid split. Yeah. I think probably pretty obvious. Yeah.
That's awesome. Hey guys, how about the last one here, case 3? What initial impressions do you get from a fracture surgeon fixation reduction point of view?
Yeah, I mean, I think these so the tuberosities are going to be key. We see the greater clearly, the lesser is probably off as well. And, I think this is all about elevator maneuvers to dock the medial hinge, which is usually intact. It kind of fails in tension on the medial side, but that's a key to the inherent stability. And then often augmentation, because there's a big impaction zone that's left behind once the head angle is restored. And reasonably good outcomes with often an intact kind of vascularity around the head.
I also find that you can typically get a pretty good view of the reduction of the greater tuberosity with these. They're a little bit of a shell of a bone, but typically once you get the head back in place, the tuberosity will typically nicely fit in position here, which is kind of nice actually. So I totally agree with Mike, but I also think that I typically find a decent read for the tuberosity with these, typically.
Yeah. So just off of these 3 sets of injury x-rays, it's a ton of information that you guys have already been able to kind of anticipate the if I can use the term snakes in the grass, the challenges, the potential failure modes for these kinds of things, and already start thinking up of your preoperative planning and strategies to execute these. I'm going to come back to these 3 at the end of our session today and go through the stuff that I did for these 3 to hopefully illustrate some of the points that have been brought up. But for right now, we're going to go ahead and switch over to, I think Hobie is going to go ahead and go with his talk now. So I'm going to stop sharing, and then hopefully you'll be able to take over.
Am I there? Everybody can see my slides?
I
Okay,
can see
good.
them.
So I just wanted to do like some reduction techniques to try to minimize failure, like things that I do. So tips and tricks for reduction and fixation, and come up with a strategy to approach these fractures in a very consistent manner. So for the vast majority, I have kind of a very similar approach on how I try to address these. Because the more consistent I am, the less I miss taking care of important parts of these fractures. So I try to be very consistent, almost dogmatic in the way that I fix these. So I wanted to make sure I align the medial head to the medial shaft in some fashion. Varus, valgus, I think the medial head to medial shaft is very important. So correcting varus and valgus in the sagittal plane is a matter to me of achieving length first and then trying to correct your varus and valgus. I like to use K-wires always from the anterior shaft into the posterior head. I can keep them out of the way of my plating procedure, so I always try to keep my K-wires in that position for my provisional fixation. Reduce and secure the tuberosities. So you can use suture for the tuberosities. Sometimes you can use screws, especially for the lesser tuberosity. I think a 2/7 screw in the lesser works very well sometimes. And a lot of times your plate will capture part of the greater tuberosity depending on how big that fragment is. And then I augment if needed. I think Michael and I probably augment perhaps a little bit differently, and I'll show how I like to do it. I always use locking plate fixation for these, and then think about your screw position and depth. So a lot of folks like to ask about positioning. This is it's a ProFX table with what's called a diving board, but it's just a radiolucent table. And this is the one that I like to use because I can have the C-arm come in from the head, and then as the C-arm turns around, I can get my axillary image. So I don't have to move the arm really to get good imaging. And so this is the position that I actually prefer. Patient in this position, they're way over on the side of the table, so I could get a good AP, good axillary without moving the arm a lot. I think, understanding that a good AP of the proximal humerus is 20 to 30 degrees of external rotation, and holding them in that position the whole case will help you understand your coronal and sagittal plane alignment with truly orthogonal images. And that's what it looks like draped out. So here's one of the fractures that I have, and this is an older patient. I don't want to say elderly, but older with this displaced fracture. We've decided that we're going to operate on this, and this is maybe that posteromedial fracture that Dr. Gardner was referring to earlier. So this is what he looks like on his injury x-rays, and by the time I get him in the operating room, it looks like this. So he's kind of really sunk into his head a little bit. I think he was a little bit late getting to me. But these are the things that I do when I go through these fractures and different things that I think about. So using something, the temptation is to try to push the head up on the shaft. And I think you can use something to try to hold the head and manipulate the shaft. The head's only going to move so far. So pushing on the head a lot may not help you a lot. I think it's really trying to position the shaft underneath the head. So I always think about, I can hold the head with something and then maneuver the shaft underneath the head. Other things, you can try to lever the head or actually lever the shaft around the head to try to get length and try to get it in better position. You can do things like this. You can use a lamina spreader, and you're basically gently pulling traction on the arm at the same time, trying to get the shaft to come out to length so you can set the head on top of it. Another thing is you can get your lamina spreader in, a shoulder hook, a bolt spike, pull on the shaft, push on the head a little bit, or at least hold the head still so you can manipulate the shaft around the head. So there's 3 different devices in here, all trying to achieve length I think get this coronal plane alignment at the same time. Sometimes levering it, this is just a small Homan. Sometimes this will work where you can turn the Homan around and then you can start to lever the shaft. Basically, you're trying to get the shaft out to length and move it lateral so you can get the medial part of the head on the medial shaft. In this one, I just used a flat osteotome. And I was able to slowly kind of lever this out. There's a huge defect here. There's a large hole here. So that head does not want to sit on there in any way, shape, or form where it belongs, but eventually kind of get it levered over into a good position. And I'm trying to maintain length, and then get some wires in the provisional fixation wires from the shaft, typically anterior to posterior in the head. So it's out of the way of my plating procedure. This is what it looks like on the lateral, and I think this is really difficult. This is a read for length as well as for sagittal plane alignment. Sometimes I think getting it out to length more posteriorly is very difficult. So getting it out to length in the sagittal plane, I think, is hard. It hasn't been talked about a lot in the literature, but I think it's probably important in terms of failures and difficult to do. Here I'm probably maybe still a little bit short, but I've got probably a decent cortical reduction in the front. So I wire it up and try to get this thing to sit still long enough for me to fix it. Here's a large hole. I think I have pretty good medial contact. I've got my wires in position. I can actually reduce this cortical piece of bone that represents the kind of cortical attachment to the greater tuberosity there, get that in good position. And then for augmentation for this thing is going to just constantly want to fall back onto the shaft. And I think, failures related to inadequate augmentation, I think, are not uncommon. There is not a lot of head there to put screws in to support this. So I like calcium phosphate cement myself. I think it fills in the defect pretty nicely. It's relatively easy, although it's perhaps a little more expensive. And then getting your plate in a good position and trying to figure out really where your screws are going to go, the position of your wires. When you put your initial screws in the shaft, you always got to consider not over lateralizing the shaft. And I think we'll find out later that's kind of a recently published issue of over lateralizing the shaft. And then in the sagittal plane, getting your plate to sit in a good position in the sagittal plane so your screws really spread out in the head. I think it's very easy for your screws to all go anterior or all go posterior. And so getting your plate to really sit where you want it to sit so those screws nicely spread out in the head is challenging. So typically I'll put in this kind of the oblong screw in this particular plate first. I can rotate it around that screw. I can move it up and down a little bit so I can try to fine tune adjustments to get it in a good place. I think when you have these fractures that are this unstable, it's really hard to hold them there and then get your fixation in exactly the way you want. So in the end, this is where I got this patient. I think I got a pretty good reduction. I think my sagittal plane reduction is probably not perfect. I have good augmentation. I think I have pretty good fixation. Ultimately did go on to heal. This is about 3 months later, doing reasonably well with that fracture. So that is just some of my reduction and provisional fixation techniques. Do you want me to move on to another case, Dave, or do you want to talk about that and go through that one a little bit?
No, that was great. I think we can. I just have one question for both you guys, actually. I've been in situations where you put that plate on, and the question is, how do you know where it goes? Like sometimes, it has a pre-contour to it. Sometimes it looks like it's coming a little too high. I should put the screws in the right spots. Do you have any priorities for how that plate goes, or how do you use these periarticular type plates around the proximal humerus?
Yeah. So, I mean, for me, I will argue my calcar screws are not perfectly placed here. I think when for me, if I'm going to get my calcar screws sitting right on the calcar, it's going to maybe even almost exit the head there. So I didn't think I was probably going to get my calcar screws exactly where I wanted. but I will typically start by putting this oblong screw in first, because I know I can still move my plate up and down. And then I put the screw in drill guide here, and then there's a little smooth insertion thing that'll go inside that drill guide. And then I just put a wire and see where that wire is going to end up, because that'll tell me about where my Calcar screws are going to end up. I also think in large men, if you move this all the way down here, you have, almost no fixation up at the top. In some women, they're very small. You have your Calcar screws sitting right on the Calcar, and the plate is still up here, almost impinging at the top. So for me, I guess my trick is I put in this oblong screw first. I move it up and down. I try to make sure my Calcar screw is close to where I want it. And then in the sagittal plane, make sure my screws are going to spread out into the head as best I can.
Mike, do you have any comments on plate positioning?
Yeah, my only comment would be, for a while, I was positioning the plate first based on the Calcar screws, and it's a little finicky and futzy to do. And I don't think it matters as much as, like Hobie just described, the plate being too proximal. So I kind of sit it radiographically where I think it's optimized at the top of the plate. And like, even if in a smaller patient, this lower row of Calcar screws is distal to the head, the next row up gets into the inferior head seemingly adequately. So yeah, that's about it.
Yeah, I tend to put the priority for the Calcar screws in a good spot. It may not be a perfect spot, but for the fracture, I think it's going to be in a good spot. Yeah. And then next priority is going to be whether the plate's going to impinge or not. And then the third priority is the shape of the plate relative to the proximal humerus. If it's a little off, that's the last thing I care about. So long as this Calcar screws are in a pretty good spot, as long as it's not too proud or impinging, then that's the next one. But I think that's kind of the thought process, at least for me. The other thing too is, if the screws are not in the right spots is how you imagine, double check your reduction, because you may have things not nearly as well reduced as possible, even in the bigger person or the smaller person.
I also think about the Calcar screws. This one, I can get the medial part of the head really sitting nicely on the medial part of the shaft. In those where you have comminution here, where you don't have, where maybe you don't have a good medial hinge, I think that's where your augmentation and everything becomes even more important, right? You're not going to get good Calcar screws. You're not going to have good medial cortical contact. And I think that's where augmentation becomes maybe even more important, maybe more important than plate position for some of those.
That's good. Hey, Hobie, you want to go to your next one?
So this is another fracture pattern. This is another impacted fracture pattern. CT, I think, can be very helpful to understand the tuberosities. Like, understand, are they together as one piece? Are they separate pieces? How far displaced are they? I don't know if that makes a difference for surgical approaches for some folks, but I think understanding the tuberosities, at least for me, can be very helpful. So CT sometimes helps me understand what the status of my tuberosities is like. For this one, it looks like maybe there's an intact medial hinge, at least, getting started. And then as we start to go through this, I realize that there isn't an intact medial hinge. So this is just kind of my reduction strategy and how I'm trying to put this together. And I actually have maybe an issue with this one I can ask you guys about. But here again, I'm going to see if I can start to lever the head in a good position relative to the shaft, which means I'm actually moving the shaft. I'm not really moving the head that much, and try to get this in a good position where I can start to really pull the shaft out to length. So I'm applying a little bit of traction, and I'm trying to use this Homan as a lever to get the head back into a good position. And as I do that, I realize that medial hinge really isn't attached to the head. So I don't have the medial hinge that I thought I had when I started out. So now it's a matter of trying to maybe guesstimate where this belongs on the shaft. Sometimes I find when the tuberosities are displaced, you can actually look inside there and you can see the medial shaft and you can see the head, and you can kind of get not a direct reduction. I wouldn't call it a direct reduction, but you can get a sense of, do I have the head sitting on the shaft in the right place? This one without the medial hinge, I think it makes it extremely difficult to understand where you are. So some of these, I'm not going to lie, I think sometimes we're kind of guessing. We're kind of like trying to make it look right. Also notice that the tuberosities here are kind of crushed, and they're really not up in the position that they belong in, unless I have the head over reduced, which I think is kind of hard to do. On the other projection, it looks like I probably have a decent reduction here. I'm trying to kind of figure out if this shaft looks like it's out to length, because I think length is difficult on the other image. So I'm going to go to my other view and see if it looks like I'm out to length, and get some K-wires in it again, anterior shaft to posterior head, to try to hold that in position. And then this is where I have issues, and you guys might be able to help me with this, but when you have this crushed greater tuberosity, I put sutures in this, I can manipulate it, but trying to get it kind of back up into position, sometimes they're actually crushed down. I have a difficult time getting them to go back up where they belong. So I try to push on them. I try to use a lateral read over here if I have one, to kind of see where it is and see if I can tuck this in where it belongs. But I find these to be quite challenging for me. Trying to get my plate in good position. And again, fixing it to the shaft first, trying to make sure that I don't over lateralize the shaft and have the head and shaft kind of fall off of one another and not have any medial cortical contact at all, is something I try to avoid. So I try not to over medialize. And then again, trying to plan the position of my plate on this view to see where my screws are going to go. I don't want them to go all anterior, but I think that's difficult to control at times. And this is an example where my plate's probably not perfectly positioned and my screws are going more anterior in the head than they are posterior in the head. This one, I really tried to get my calcar screws perhaps a little bit closer. I mean, this is a small fragment of bone, so I do have some contact there, but certainly not as much as I would like. So I probably focused on my calcar screws a little bit more in this one. But again, I think getting the plate just sitting perfectly on the lateral projection is very difficult to get your screws to go exactly where you want to go. And maybe you guys have a good trick for that one for me. But this is at 6 months, healed, didn't have a failure, has reasonable function. Yeah, and that's my second case. And if you look, you'll notice that it looks like we were talking about. The plate is almost, very proximal here, yet my calcar screws are in about the right position. So this is a smaller, female patient where I think maybe this becomes more of an issue.
For me, Hobie, I think it looks great. I think this is as much as we don't use it anymore, a closed reduction and percutaneous pinning, which was something that I kind of was taught by Steve Benerska, and I have to say many of these fractures are just not clampable, and so for me, the strategies of really understanding your radiographs, really understanding neck shaft angle, medial lateralization, retroversion, anteversion, and seeing the radiographic projections and being able to basically provisionally secure them with indirect reduction reads, which means it's all about understanding the radiographs, has been just a huge help for me, even with open techniques, because I find once I do my exposure, and I'm a delta pectoral exposure kind of person, I think Mike's going to talk to us about some other kinds of exposures, which is going to be awesome. To me, so much of my reduction tends to still be radiographic and indirect. So I think that when you don't have clampable fractures or you have comminution, it's for me really kind of going back to the perk pinning kind of days, has been very good, because I use those same principles of reduction and sequencing the fixation just basically the same way.
So I have one more case. This is another older patient with a varus fracture pattern, and maybe just some different reduction techniques and way of looking at it. So I think a lot of times particularly in this pattern where it falls off posteriorly, it's in varus. A lot of times the anterior cortex is a very good place to look for to use as your gauge of length in the sagittal plane. So I think this is very helpful where you can use the anterior cortex. You can typically get a good reduction of these fracture fragments and understand that you're out to length, I think, with this particular pattern. And so I'm just trying to push the head out to length. And I know posteriorly it may be difficult to see, to get to judge, to understand, but at least anteriorly here, I can feel pretty good about my length. And I can try to understand the relationship of the head to the shaft and what that angle should be. You know, it is slightly, what would that be? Retroverted a little bit. And that's probably where it belongs. But this is just an example of trying to get length in the sagittal plane and then having my wires all set up, they're ready to go. So as soon as I think I have it, I can drive those wires in and try to maintain that reduction. Now, this is also a good example of, I think my screw spread in the head is pretty good, but when I put this screw in, I probably tightened it maybe a little more than I should, and I lateralized the shaft just a little bit. And I think this is a real issue for varus fractures. I do have my calcar screws sitting pretty nicely close to the shaft, but I would argue I probably over lateralized this a little bit. So if I had this to do again, when I put this screw in to get my plate in position, if it looks like it's going to over lateralize the shaft, then I'll just use locking screws in the shaft and abandon my non-locking fixation in the shaft, just so I don't over lateralize it. So I think that's one of the takeaways for me for this case is, one, the varus patterns are difficult. I think I like to look anteriorly if I can get a good read there for length, and then kind of see it indirectly on my x-ray if it looks good posteriorly, and then being careful not to over lateralize the shaft with the varus pattern. I of course got lucky, and I think this patient healed and did pretty well at 5 months. However, I would say I had at least one error there, and perhaps my calcar screw placement is what saved me in this one. But I think it's very difficult, and I think it's very easy to over lateralize the shaft with the non-locking screw.
Hey, Hobie, just to go through a couple questions that have popped up. What approach are you using for these cases?
Yeah, so I will use either a deltopectoral, or I'll use the deltoid splitting, anterolateral acromial approach as described by Dr. Gardner. But I'm probably not as facile with that approach as he is. So the more comminuted, the more complicated, those with associated dislocations, those where the lesser tuberosity will sometimes break off with a piece of the head. Those fractures I do through a deltopec, but two-part fractures, those with a nice big greater tuberosity fracture that's really around the back with an otherwise relatively simple pattern, I'm very comfortable doing those through a more deltoid splitting approach. Yeah. So I kind of go back and forth.
Are all these people supine on a radiolucent flat table?
Yes, I do them all supine. We have that what we call diving board table that I like to use. So I do them supine. I don't have to move the arm really for imaging. I move the C arm instead. And for me, that's just been the best position for me to do them in.
Yeah. Hey, this one's for both you guys. Do you, if you had your choice between putting your calcar screws in the perfect position, but it comes at the cost of the plate riding high and being a little bit potential for impingement, would you put those calcar screws and take the impingement, or would you drop the plate down, have suboptimal calcar screws, yet not a problem with impinging?
I would drop the plate down and not risk impingement being an issue, and figure out other ways to get screws into the inframedial head.
Yeah. What I've actually done a few times in that situation is I will actually have my calcar screw come here and come out the shaft and kind of sit just underneath the head. Just let it sit there a couple of millimeters out, because I know that's not going to engage their glenoid. And I think it probably still holds the head up, even though it may look a little funny on the x-ray because it's not in the head, it's actually underneath it.
Yeah, I've done that too. I try to do as big a compromise as possible. I think it's a little bit risky to leave that inferior head completely implant free or not have, the beam of support like you're describing underneath the head to prevent the caudal translation. But yeah, I mean, I don't like having people with a really proud plate and impinging. That's not so hot either. So some other strategies to kind of compromise between those two is important. That's
Okay,
great. Hobie, have you wrapped? Is that your last case, Hobie?
that's my last case.
Perfect. Michael, are you ready to roll?
Yeah.
Yeah.
So I will go through this relatively quickly. These are you guys there? All
Yeah,
my
I'm here.
okay, all my videos just froze. I assume I'm still on here. There we go. So a lot of pictures in here. I'll go through these relatively, and hopefully some of the other questions that are in there will be addressed here. So just start by showing a case. It turns out this is similar to a few that we've seen. Varus, unstable appearing, 4-part type of fracture. And so we could be thinking about this, and we'll return to this at the end to kind of see how we went about addressing this. So I'll go briefly through, some of the problems with the delta pectoral approach when I do it. And again, admittedly, not as facile probably. Accessing the posteriorly displaced tuberosity from an anterior approach is one kind of significant one. And then just retraction of the muscle mass of the deltoid with internal rotation of the provisionally reduced fracture are problematic for me. So I do essentially all fractures through a deltoid split approach or the anterolateral acromial. And we'll just go through a few brief steps here. So this is my positioning too, I think very similar to Hobie's, reversed on a diving board. Now I used to use kind of this plexiglass padded, and I will say one of the most helpful changes I've made in the way I do this is getting this Spider. I think Spider is the brand, but it's an arm holder that's got a pneumatic foot pedal. And it makes holding the arm, it makes positioning the arm to help the reductions much easier. I had been like putting padded Mayo stands and IO banding all these bumps, and someone's still holding the arm, and so it's a hassle. This makes a huge difference, I think. Still can come up to an axillary view without moving the arm extensively, so very helpful.
I have to say, Michael, I've just relatively recently been introduced to that Spider type arm holding type device, and I completely agree with you. It's been great for scapuloglenoid stuff, and of course, revolutionizes the fatigue factor with holding the arm for proximal humerus.
Absolutely.
Totally.
So incision for a deltoid split, I generally make it just posterior to the anterolateral corner here. The main event is the anterior motor branch of the axillary nerve, and that crosses predictably at 65 millimeters from the acromion. So I measure it, mark it on the skin. And then the incision just kind of goes down the humeral shaft. The interval trends a little anteriorly, and usually the shaft is displaced anteriorly. So if you want to trend this anteriorly, that can be a little helpful as you get deeper. Even bigger patients or with a lot of swelling, the deltoid fascia comes relatively quickly, very superficial. So we find that sometimes you see the interval between the anterior and the middle heads of the deltoid as a nice visual kind of white stripe, but unfortunately, usually not. This is what it can look like if you do. More often for me, it's a palpation, and this is just a cadaver, but you can see the topography just in this picture. And if you run your finger side to side, you can feel where the interval is. And if you gently spread, you'll find tendon on each side of your interval, and then you can extend it deep and distal. So still working proximal, you see the nerve marking on the skin where we know we're proximal to it. So these strands of bursa, we're confident are not the nerve. It's important you get into the bursa. I actually excise the bursa kind of in an ellipse that I see here, just to make sure the plate can get onto that greater tuberosity so we don't get the lateralization later. And it's also important to get deep to this layer because we're going to need to get deep to the nerve, and the nerve lies on the undersurface of the deep deltoid fascia. So we identify the nerve, the shaft distal, cadaver view of the nerve just skeletonized. You obviously, maybe not obviously, but you don't need to skeletonize it to this extent when you're doing this procedure. You really just need to palpate it, make sure it's not incarcerated in the fracture, and then slide the plate underneath it. So this is a valgus fracture pattern. I'll show some reduction fluoro sequences in a minute, but just to show you what you see. So you see the edges of the tuberosities, you see the articular surface of the head. So it's a lateral approach for lateral fracture pathology, which is why I like it. And it just makes the subsequent steps a little bit easier, I think. So we work an elevator in, different patient, but same pattern. We pop the head back up to the glenoid, and then we leave it, have a defect where the tuberosities have been splayed. And then with rotator cuff sutures, you can simply pull these back together as just kind of a first step in the reduction sequence. And you can still work freer elevators in these fracture lines and fine tune the position of the head relative to the tuberosities in the shaft. And then after the fracture is reduced, we can slide the plate deep to the nerve under relatively little tension and go from there. So I'll just go through some reduction sequences. I think these fractures are very hard. There are a lot of ways to go about doing this. And so I think it's very helpful when you first start to kind of find a sequence and just get used to doing it that way. It's helpful to be facile at a certain sequence. And again, so these are not like the best or the right way, but kind of some of the ways I've just gotten used to doing it. I use a broad-based elevator in almost every case. And this is just very simple. You see here in a kind of minimally displaced, but varus kind of unstable fracture, we lift the head back up onto the shaft, and we're focusing on restoring this Shenton line or calcar line here. And so that's our first goal at this kind of first step here. I use from a lateral approach, I think it's a little bit easier to use this indirect reduction tool of a cortical screw. So most patterns, I try to over medialize the shaft and get it in a little more valgus. And then you can just simply dial this down to wherever you want to lateralize the shaft to, and then you can stop and fix it wherever you want the shaft head relationship to be. Interesting, and we've talked about this a few times now. This was a study out of Cleveland using about 1,000 human bones from a museum of bones, and they put plates on the bones, and they found that they don't fit the human anatomy very well. And so if you're using the plate as a template, you just need to be careful and watch what's happening as you're pulling fracture fragments to the plate. And here's an example of that. This patient was about 4 or 5 weeks out, kind of subacute. So we've got some K-wire joysticks in the head. We've got our plate position. This is a little too proximal, to my eye, talking about plate position a minute ago. But we've got things reasonable, and just by gentle tightening of a screw, you see what's happened here. So we've over-lateralized, we've uncovered mechanically this medial head. And so this is problematic. So we don't want to leave the OR like this. And so what we did here, we put some locking screws into the head and kind of a loose cortical screw in the shaft, and just remedialize the shaft with a lamina spreader to the point where we like it. And then to reiterate Dave's point, if we lock the plate off of the bone, but the fracture has some inherent stability, that's okay. And we don't care that much that the plate is not sitting flush to bone in this situation. And one of the things I think happens, this patient had a very kind of hypertrophic bursa, wasn't adequately debrided. So the top of the plate sits off a little bit. And then so when the shaft comes over, it doesn't realign too well. So here's just another example. This is a little bit of a full sequence. This was a girl who had her arm hanging out the car and it rolled over. So pretty comminuted and displaced, but essentially a 4-part valgus fracture pattern. So my first steps typically are elevator to control the head, and then sutures to control the greater tuberosity. And I'll work to get these two fragments together as a step. You don't see the sutures, obviously. So I'll wire those, and then I'll wire the proximal plate to the reconstructed proximal fragment. So we've got essentially a surgical neck fracture now, with the lesser that will be worked on separately. And this is a great time to get a good axillary view, because we need to make sure that any retroversion in an anatomic neck fracture that you see here is accounted for and reduced on the axillary view. So we saw a lot of Hobie's lamina spreaders being selectively placed posteriorly. for this reduction kind of parameter. And similarly, we've got an elevator posteriorly restoring this retroversion. Now, more commonly in a surgical neck fracture, I find, so you get the pull of the pec and anteriorly translates. Also, the arm kind of sags. And this is the situation where I think the spider is very helpful. So our assessment here was plate relative to the head is pretty good. And to one of Hobie's points, I use these top two wires that go coaxial with the plate to determine where the position is of the plate to the head. And then you know it's not rotated anteriorly or posteriorly. And then we think, all right, now we just need to elevate the shaft. And now our sagittal plane alignment is better. And then we can just hold it there with the arm holder, as opposed to kind of bumping it up or somebody just holding the arm up, etc. So then we've got the plate shaft realigned to the humeral shaft, and then we use this long cortical reduction screw, and we lateralize it where we like it. And then we add our final fixation, and we end up with a reasonable reduction here. I think the more difficult pattern, it's less common, but more problematic, is this varus kind of shear. So in this now, we see the calcar comminution, unlike in the last valgus, in the last case where there's a little more tension failure on the medial side. So a little bit of a composite. We've got K-wire joysticks, and they need to be styled. These are 6'2" K-wires. If you really want a lot of power, you need something more than 6'2" K-wires, I think. Tuberosity suture. So even if the tuberosity is not fractured, sutures in the cuff can help the coronal plane alignment to mobilize the head. Elevator, like I mentioned a few times. And then if we leave the plate off the bone, sometimes just abducting the shaft can help restore our varus valgus alignment, our neck shaft angle. And again, we put in a screw that we know is going to be too long. We pull the shaft over to where we think it's going to be reasonable, and we add our fixation, and we've got load screws, reasonable neck shaft angle, etc. It's kind of just a little bit of a sidebar. This was a subacute patient who got in there, lifted the head back up, good AP and lateral views. And then interestingly, we took out the elevator and just ranged it around. And this was so inherently stable. It was amazing. It was great to see. It's just a good reminder of what good inherent stability we get when we've got good bone reduction. And so it really should be a priority to minimize implant stresses. And here's our final construct. And so this is very displaced fracture. Just another thing to think about. I'll show a case in a minute. So there's a fibula strut allograft kind of in the medial shaft here. And this gives us an added opportunity, I think, to use cortical reduction screws. So we wouldn't want to leave this like this with the head overhanging the medial shaft. And so using this screw, we can push the fibula from the inside and medialize the shaft and kind of fine tune and dial it so that we've got real good apposition of this medial, so it's a little bit comminuted. And then we can lock the fibula in place. So back to our case, 67-year-old female tripped on a cat. So what we decided to do here was, so we start deltoid split approach, elevator to get it up on the shaft, try to dock the medial side. It's clearly in valgus right here, but that's easy to change. Once we get the medial side on, we can push this up slowly in a very controlled manner here. Decided we wanted to use a fibula given her age, etc. Kind of its small head, kind of inherently unstable pattern. So we try to tip the fibula medially, or I try to, in these cases, tip it over, and you see how it's long here. So it's a little too long. I usually end up cutting these a few times, but it goes right in through the lateral approach, kind of in the neck fracture line. So you see here it's shorter. So now it's able to tip further. And this is really mechanically, I think, where it's helpful in this kind of fracture pattern. So we add some wires, hold it in place out of the way of the plate. And then the plate goes on. We check the fibula position on the axillary view as well. And we add our final fixation. And once the fibula is in, it's hard to miss it with a locking screw. So you don't need to worry about kind of where it is and whether you can hit it to hold it there. There are enough screws that crisscross and stuff that you kind of can't miss. So that's it. And then the journal thing we'll do next.
Yeah, can I stop you there for a second, Mike? Just a couple comments. I just got to tell people that are watching this that those are some masterful strategies, techniques, and abilities. And those cases look just fantastic, and they are made to look easy, and they are not easy. So a couple questions for you, Michael. I'm a deltopectoral guy. That's just what I do. I only use the deltoid splitting for like isolated greater tuberosity fractures. So if I'm going to start doing deltoid splitting, what fracture patterns do you think I should start with, and which one should I avoid until I get more facile with it?
Totally. So, I think you definitely want to avoid patterns that involve a lesser tuberosity. You need to dissect a little anteriorly. It puts a little tension on the nerve to access the edge of the lesser to kind of remedialize it. It's just, you got to work past the biceps tendon sometimes from the lateral side. So that's not easy. I think the ideal ones are like valgus fracture patterns, because the reduction it needs is a lateral elevator to kind of shift. So it's all kind of superficial in the wound. So you don't need to do a lot of kind of deep work. And it's also just a little bit easier to get the reduction. So I think both you guys made the point, probably more fracture lines are indirect fluoroscopically based on a deltoid split. And so it's a little harder. So if you've got a varus pattern that's fallen off the medial side and you need to realign that by moving shaft and head simultaneously, and you need the arm being held, it's just a little bit, I think it's a little bit harder. So valgus ones with what seem to be an intact medial hinge that need a little realignment, bring the greater around. I think those are good ones to start, so 2-part, simple varus, but, valgus with a greater, I think is reasonable.
I think one of the problems I had with early on use of the fibula was what you described. The fibula was too long. The fibula ended up being more of a medullary location than buttressing up into that caudal inferior medial head, which is the whole point of why you want it there, is to help support that inferior head fragment, if that's the way that you're choosing to use it. Those are really good tips and points as to, if you're going to go with that, recognize you're using it in the most unstable fracture patterns, number one, and what's it going to stabilize? Well, it's really going to be stabilizing that inferior head.
Yeah. But I think some people will use them for valgus patterns, or you actually want it on the apex of the head, so then it's more vertical. I generally don't. I use more for those patterns like Hobie showed, a little more volumetric cement type things.
Yeah. All right. I'm just reading some of the questions. One of the participants is wondering about getting those calcar screws in and worrying about the axillary nerve. What are you doing it seems like competing interests. We want the mechanics of the calcar screws, but we got the biology of the nerve in the way. How are you avoiding that, Mike? Are you always finding the nerve and putting the sleeves around them, and that's the simplest way?
Yeah, so that's another thing. It's a real thing, is that, so I generally palpate the nerve to get kind of the plate in early, but then when it comes time for the screw, so in this plate that I use and I've shown these x-rays, those calcar screws, if the plate's positioned correctly, are right under the nerve actually. So you need to kind of tease off the investing tissue and retract it. It's either north or south, but it can be both. So so the nerve takes a little bit of move it out of the way and put in the sleeves for the calcar screws.
Mike, you ever have any troubles from your arthroplasty colleagues for putting fibulas in when they have to sometimes go back and deal with them?
Yeah, I haven't, and I think the reason is what we were just talking about. The real gripes come when you've got a long fibula stuck down in the shaft and it's fully healed, and then they need to ream a canal.
Yeah.
And that's hard. And so, but I don't do a ton that way. Most of mine are short and oblique, and so that's easy to drill out and find the native canal.
Yeah, I've taken my share of them out for non-union stuff, and I found them to not just in the proximal humerus, but elsewhere, femurs and stuff like that. They're manageable. It's not a kiss of death for the arthroplasty guy or for the revision by any stretch of the imagination. So, good stuff. Mike, would you mind going through that journal article now, and then we'll start getting in shape for wrapping up?
Okay, so nice paper just came out in May this month in Journal of Orthopedic Trauma out of Canada. So brief methods: 110 consecutive patients treated with ORIF with a lock plate construct. Interestingly, exactly half of these patients had a complication and half did not. So that tells you first off how common these complications can be. And then basically they ran a bunch of regression analyses to determine what specific risk factors for complications were. And one of the great things about this paper is they really look close, that they analyze factors that I think are really, the state of the art in how we look at these, and things that we think about that are important, things that we've heard throughout the last hour that really had not yet been really looked at. So that's the brief method. So they came up with 4 conclusions that I think are worth highlighting. So I just kind of highlighted those here, and here they are. So somebody asked about screw lengths. Hobie screws are super deep right against the articular surface. Okay, you have a lot of problems there in Chicago, I would imagine, but screws greater than 45 millimeters in the 2 most proximal rows, problematic. So I think we've all seen, even when well fixed, and even when the patient goes on to heal, these often settle a little bit. And when they do settle, the proximal screws end up being the first to penetrate. And they probably don't offer as much mechanically as the other positions. So I generally actually leave these out. They found if the top screws are 45 millimeters or long, significantly increased risk, 5-fold greater of a chance of a complication. Next, again, we've heard multiple times, lateral translation of the shaft or excessive humeral head offset. So this, we've said in a few different ways, but head hanging off the medial side such that the inframedial head is not supported by anything, tripled the risk of reduction loss. Interesting. Medial support. So they looked at a few different ways. So absence of medial support by bone contact increased the risk of complication 3-fold. The absence of medial support and the absence of calcar screws increased the risk of cutout by 5. Now, interestingly, sidebar, this same group presented a highlight paper at the OTA a few years ago and kind of trashed the deltoid split approach as having more complications. And when you look at their data, it turns out the ones that they used the deltoid, it wasn't really a deltoid split approach, it was really kind of a percutaneous thing. So in all of those patients who they use a lateral split approach, in most of those patients, they did not have calcar screws. So I would say if you come across that paper, and it's published, I blank on where it's published right now, but probably more about the fixation construct than the approach itself that was problematic in that paper. Anyway, calcar screws are important. It's pretty clear by now.
And Mike, the inference there is that the calcar screws were not placed in because of the rest of the axillary nerve.
Exactly. So if you use a percutaneous, like 2-window technique, you can't put low screws in, and that can be okay for some simple, stable fracture patterns. But if you want to put those screws in, you need to open it and you need to move the nerve out of the way. And then finally, reduction quality, looking at kind of neck shaft angle, varus valgus, unacceptable reduction, which is essentially varus neck shaft angle, increase the risk of complications 4-fold. So really good study, I think, to have in our literature, very helpful. And so in summary, keep the proximal screws short or avoid, establish calcar bone contact when possible, use low calcar screws, again, depending on plate position, but try to get something into the medial inferior head, avoid lateral translation of the shaft, and don't leave the OR with the head in varus.
That was great, Mike. Thanks for doing that. If I can go back to sharing my screen now and see if I can make this work. Is all that satisfactory there, guys?
Looks good.
All right, great. So I'm just going to finish this up with what I did with these three cases and what are the things that my gut was telling me and agonizing about this particular one. And hopefully this kind of just shows you a summation of some of the strategies that you've seen here. These were all done through delta pectoral. These were all done supine, radiolucent arm, a radiolucent tabletop. The C-arm was also always brought in from the head of the bed. And my viewing for this is always going to be an AP and an axillary lateral. And so just like the guys have said, you know, the strategies for me for this is really realigning two components initially. It's always about the head and the shaft relationship. So it's correcting translation and angulation, right? So in the frontal view or in the AP view, we're really trying to restore medial translation, lateral translation, which I hope is corroborated by that paper that Mike just presented, and then angulation, right? Frontal plane, so getting the neck shaft angle, so we're avoiding the varus. And on the lateral view, we're trying to restore the version. And so that's my strategies here. One of the things that you might be able to pick up on here, this is just a shoulder hook that's been placed in, so I have a better control of the shaft component. I try to really keep my K-wires relatively low. I use a lot of K-wires, guilty. But one thing I really try to make sure of is that none of these K-wires inadvertently cross out of the chondral surface, because that'll be the K-wire that you cut with your drill bit or when you put in your screw or you can't get out. So always be, whenever I put in wires, they're in locations where I'm ready to accept them as definitive implants, just in case something happens. And that means they're not going to be in the glenoid, they're not going to be outside of that articular surface, and really try to pay attention to that as best as I can. Probably in the next few slides, you'll see a bunch that are out, but I try to keep them out of the way as best as I can. So here he is here now. So I think these are pretty good final films. You can see that Mike, just like what Mike talked about, this is unstable posteromedially. He's got a cortical fracture fragment that's out the back. It's not a tuberosity. I think it's posterior cortex right at the metaphysis of the surgical neck. Here I've got my implant in. Here he is at 6 weeks, guys. He's got the two calcar screws are backed up. And then at 12, and I left him alone at this point. I thought we were on our way to healing. What do you think about what's happened there and why did that occur?
You know, there's no clear reason in my mind. I mean, unfortunately, sometimes it just doesn't work out. I can't pinpoint anything that I would have done differently or some technical thing that there's like a red flag. But I don't know, Hobie, what do you think?
Yeah, I don't see any red flags other than, you know, that it's unstable because that posteromedial fracture fragment is just, you just can't really reduce that. You can't really get that in a good position to tolerate load. So I think maybe it's a bit of bad luck. I think you could argue to maybe have your calcar screws maybe just a little bit closer to the calcar, but I don't know that that would have prevented it. I always look at my cortical reduction on my sagittal plane image. Like, if I have a cortical reduction there, I feel a lot better if it's comminuted posteriorly. But I think initially you had a good reduction there.
Yeah, that's the thing I thought of is in this particular fracture pattern, I thought maybe I should have had those calcar screws a little bit more caudal. And they may have helped support that, because it looks like he's trying to drift back into that posteromedial kind of displacement. And that was my sense. Would you guys have done anything at 6 weeks? I left him. I let it ride and thinking he had 6 weeks of healing for a fairly straightforward otherwise fracture. Would you guys have hopped in there sooner?
You know, probably only because the proximal screws are a little long and they're about to penetrate. And I think the horse is out of the barn in terms of the instability at this point. Like, I don't think, like, these aren't the type of ones that like will impact and heal typically once they've shaken loose a little bit.
Yeah.
It's weird because oh, sorry.
Go ahead, Obi.
It's weird because I feel like most of these by 8 weeks, you know, I have them doing unlimited things in therapy. I let them do rotator cuff strengthening by 8 weeks. Seems to me like the vast majority of these, in my experience, they fail either very early or they heal pretty quickly. I think I don't know. I may have actually watched this one for a little bit, because I think he's probably got to be getting close to healing at 6 weeks. He's only got, 3 more weeks. The thing should be healed, but I don't know.
Yeah. For me, the first thing I think about after the screw should have been lower was, oh, they're cross-threaded. Got to be cross-threaded. But boy, they sure look so parallel on that initial AP view that I was thinking, well, pretty darn good symmetrical cross-threading if that's the case. I did take him on back. I did, and he was bothered by the prominence of the screws. That's what bothered him. But if I look critically at this, I think he has drifted into a little bit of varus. You see the proximal part of the plate bone interface now has some gap, whereas prior it didn't have gap. And I think he has settled in that. I ended up replacing those screws. New screws threaded, they captured, they locked, and that was his saga for him. So I think that initial posteromedial pattern, I think, and if I was to do this again, I'd pay attention to really making sure that those screws were really low down into that inferior head, probably a little bit better than I had in that particular situation. I agree. I look at that posterior piece back in here. I still don't think there's anything I could have done, certainly through a deltopectoral approach, that would have been, worthwhile. Could have made the X-ray look a little bit different, but I don't think it would have added much unless I got lucky with it.
No, Dave, you took him back at 12 weeks?
Yeah, I did, and it was because he couldn't stand the tether or the lump in his deltoid.
Right. Was he largely or very close to being healed by then? Did it move much once you took the hardware out?
No, it didn't move much, to the point where I debated should I even put anything back in.
Right.
But then I thought it was going to do what Mike said. Then those proximal screws, it's holding off of that. Then those things cut as he continues to fall down. So I erred on the side of good. Just put them right on back in, tighten them on down, and ride it out. And he did okay. But the reason I inserted them was I was worried that the proximal stuff was going to be doing all the work in a partially healed fracture that just needed a little bit more help. That was the rationale. Don't know if it was right or not, but that's what I was thinking.
I would have definitely put hardware back in, but I was just curious how well healed he probably was by 12 weeks. I get a sense that these fractures actually heal relatively quickly.
Yeah, I think he was healed largely. Okay, this guy. Boy, this thing, when I looked at this, was screaming dead head for obvious reasons. And this guy is going to have an arthroplasty in his future. And he's going to have it probably at far too young an age. And so I really want to make sure that I can get his tuberosities healed as best as I can, and get them as not just united, but united in a reasonably anatomic position. I think that gives the arthroplasty guys a lot more options, and maybe a more predictable way of going through his initial arthroplasty, or more options anyway, and then from less to more. At least that's what my thinking was. This also came, interestingly, with a complete pec tendon rupture off of his proximal humerus, which embarrassingly took me a little while to figure out, like, why can I see everything so easily around here? And it was because his pec tendon had been completely avulsed off of the proximal humerus. But just to go through this again, to hammer home some of the same points, once again, we've kind of got a shoulder hook helping me with grabbing onto the humeral shaft component. Here I'm trying to restore, once again, translation angulation, and recognize here that I've got him secured down low. I can use this as a hinge point because he's in valgus and he doesn't have enough retroversion. So I can get my spike pusher ready. I can back out some wires. Once again, use these caudal wires as my hinge, so it's going to protect translation, but allow me to angulate, and I can move his head back up. And now I have a space for the greater tuberosity to get reduced. And now I can stick that. And I think with a lot of these, the tuberosities offer a lot of closure of the dead space or the perceived gap. There's no question there's a lot of bone crushing in some of these, but I think that helps me too, is when I get those tuberosities back. Fortunately, the bone gaps or defects seem to be a little bit less. But this was a real challenging one, of course, because the head is dead. It doesn't have much in the way of medial support. This is definitely one. You know, he's got some chondral screws in here, but and a little bit of bone graft substitute. But really, I'm trying to get the lesser and the greater tuberosities as lined as perfectly as possible, because I know this is going to have troubles.
How did you get the head out of the axilla?
I just went after it.
So with the pec being off, you just reached out and fish it out, I guess.
That's exactly why I was able to do that, because that pec was off and I was able to do it. I was prepared to do a counter incision to be able to get that one out of there, but his pec was off and made it available to me. That's the only thing, you know, worse than that I've had was an intrathoracic one, but that was kind of like bizarre. But this one was pretty darn displaced and yeah, completely stripped. But I want to ask you guys what you do with this. You know, like to me, this is at 10 months. You know, he's moving, and then he shows back up, and he says, you know, I think I can feel some clicking. Mm-hmm. What do you counsel these guys on with this?
I mean, now this looks healed. This is a little bit of a different settling pattern than the last one, and so I would just take these screws out, try to preserve his head and glenoid cartilage as long as possible.
Yeah, Hobie, do you have anything different?
No, I'd remove his hardware, because I think he's probably well healed at this point. I'd remove his hardware and see how he does.
Yeah, that's exactly what we did. You know, I think one thing I've learned with these ones, at least that I see that have these, you know, 100% for sure dead heads, or are at a high risk for settling. I really try to counsel these guys in the fact that the screws aren't going to be coming out of the plate, except you're in the first guy, and then they're going to penetrate through the joint surface. And so it's important for them to have some follow-up, especially if they start feeling like something's catching or clicking or doing something like that. That means it's the screws are probably starting to go through the head, and the answer to that is get those screws out of there. I think as we've learned, you know, people with avascular heads do better than people with avascular femoral heads. Mm-hmm. And so hopefully with his hardware out, he's already felt better. He's moving, he's back to work, he's doing stuff. But I have, you know, no illusions that his humeral head is going to continue to dissolve over time, and he's ultimately going to need some work. But hopefully that's in a number of years, not 2 months or something like that. So I think even these ones where you think that that there is no good future for this one, I think that fixing this in this age group is probably the only thing that you can do. I know of no other kind of intermittent strategies for these particular injury patterns.
Let me ask you this. Have you guys ever had a fracture dislocation where the head didn't die?
I probably will honestly say I don't have that kind of follow-up.
Yeah. I only bring that up because I did have a lady that's actually the neighbor of one of the cardiovascular surgeons at my hospital. And she had a shoulder dislocation. When they tried to reduce it, her head broke off. I've probably been 8 or 9 years, and she's never been back. And I still see the cardiovascular surgeon 2 or 3 times a week in the operating room. He's like, yeah, she's doing great. She's fine. So I have at least one that I know of. She may have asymptomatic AVN, but she certainly doesn't have a big problem. That's 8 or 9 years out from a fracture dislocation that actually healed and is doing fine. So I guess the point is that for the participants, you know, with these fracture dislocations, I think especially in young people, I really think they should be fixed. Give them a chance. They may have a little AVN that's asymptomatic, and they actually do pretty well for a long time.
All right, last one. This is a 55-year-old guy, falls from a ladder. He's got this particular injury pattern. Another one, not a lot of metaphysis on the medial part of the head, considerable amount of displacement of the head opposite of the glenoid, comminution of his tuberosities. This is another one that I worry about the viability of the head. But since he's not frankly dislocated out of the glenoid, I'm gonna hope that he has perforating capsular type of vessels around the posterior aspect that may keep this more viable. I think in some people, this in some circles may proceed to an immediate arthroplasty. But I can tell you that I'm 54 years old now, and if this was my shoulder, I would want mine fixed. I don't want an arthroplasty just yet.
Yeah, I think it's always worth mentioning when this topic comes up, that 8mm hinge of Hertel, it just gets a lot of press and discussion. And it's interesting because, that initial Lego paper and whatever, where they drilled a bunch of heads and laser Dopplered, and they found that, and that's where that came. That they found, the short hinge was predictive of having no blood flow in the OR. Turns out, the follow-up study of those patients 4 years later, there was no correlation to like lack of perfusion on the table and subsequent AV or reperfusion. So to everything you're saying, it's hard to predict, and it's worth fixing because you don't know what's gonna die and what's not.
Yeah, unless it's out in the back table, you never know. Just to corroborate Mike's point about the 6-2 wires, here I'm using a 4mm Schantz pin to manipulate the head. So you really need to have something kind of pretty robust to be able to do that here. And this has the depression, I think, that you were talking about, Hobie, of the tuberosity, or it seems to just be pounded down and in a really poor spot, and not behaving like we're used to, of putting sutures in and pulling it from postero-superior back into a position of being too cephalad or proximal. This one is pounded distal.
Yeah. Yeah, it's important to know it's easy to over-reduce the tuberosity. I totally agree.
Oh, yeah.
These I find them very difficult to deal with. It's hard to get that tuberosity back up where it belongs.
Yeah. So here I'm going from the inside, from the cancellous surface. I'm really trying to use the radiographic alignments that I can see on the fluoro shots over in here to try to reestablish this greater head relationship. Thinking I've got the shaft is looking pretty good relative to the head. Then I start working on the lateral tuberosity, of course, on the axillary lateral views, where you're going to see that top of the hill here with the shoulder hook. Bone graft substitute to help hold the lesser up in place, because there's no bone underneath it. It's just been crushed from that displacing force. And another guy with a reduction. You can see I think I've got his version pretty good, Dustin, here, but I just creamed his lesser tuberosity down with this plate washer kind of construct. We don't know the consequences of that, but that's the way it is. But 1 year later, he sure does look like he's got a viable vascularized head. And of all people, his screws go nowhere. His finally look like they've stayed put where I've wanted them to be and where I left them in the operating room.
Dave, maybe just for the participants, if you're going to put a screw in the lesser tuberosity, do you like to do that before you put your screws in the plate, or you do all your plate fixation first and then try to get a screw in the lesser? How do you like to do that?
I do the latter. I think it's the least, I put the least priority on it. Those screws can go in a lot of different directions. And so what you might see pick up here is that these screws I've used are cannulated ones. So if I can go back one, or two here. So as I'm putting these provisional wires in, these provisional wires are often ultimately going to be the pathways for the screws. And so I'll get an idea early on if I'm colliding. And if I'm not colliding, then I carefully put the cannulated screws over top of those wires, knowing that they've at least got a semblance of a pathway that I can rely on. But I do put them last.
Yeah.
Sweet.
All right. Well, we're in the zone of wrapping this up now, guys. I'd like to thank you all for your attention. And most importantly, I'd like to thank Michael and Hobie for sharing their expertise. These guys are really, really skilled and talented surgeons. I learn a lot from them every time, and I love listening to them talk. And I hope you guys did as well. A link to this recording will be sent out so it can be seen again, should you have the desire to do so and digest some of these points. The take-home messages I think are repeating, right? I think these are hard fractures, and And in situations where we can't use arthroplasty techniques to give people good shoulders, we have to fix them. And knowing how to be able to fix them is critical. As I think you've seen all of us, we really kind of focus on that neck shaft translation angulation and really trying to restore that medial calcar Shenton's line type of relationship early on. We use a lot of radiographic assessments because we don't often have a lot of cortical interdigitations or cortical reads to guide us with many of these reductions. If we do, that's great, but don't bank on it. And the other thing you don't bank on is having fixation for the greater tuberosity that just comes from the plate screw construct. A lot of us are using augmented sutures into the rotator cuff bone interval and tying those things down to the plate to help us out. I think that if we get the neck shaft translation angulation right, so avoid varus and avoid the lateralization of the shaft, this gives us the best mechanical environment for union, and then that allows optimum fixation placement because we're putting fixation into what is presumed to be a reduced proximal humerus. Each of these is independently critical. So fixation, stabilization of the caudal head should drive that implant placement. And I think bone defects are minimized with a really good reduction and fixation of your tuberosities as it closes or minimizes the hole that has occurred either from aging and or the fracture forces. But residual defect management, as you've seen, you use morselized allograft, you use bone graft substitutes, or even structural allograft like Michael showed with the fibula to help support that caudal head. So thanks for listening. I think that this fireside session has a real place for further AO dissemination of information, education, and knowledge. Here's some upcoming ones that are going to be coming up that I think are going to be super good. So I hope you enjoyed this session. Once again, my appreciation to Michael Gardner and Hobie Summers for participating in this for me, to Mitch Bernstein for allowing me to moderate this, and of course for the AO for putting us on like always. Hope you all
Thank you, Dave. Great session.
Thanks,
Appreciate
guys.
it.
Talk to you soon.
Thanks, guys.